Hi guys, welcome back. As usual, we're going to start with a question. A 42-year-old woman presents because she felt a lump in her right breast. She was in a minor car accident 3 weeks ago and noticed bruising over the same breast at the same time. Physical examination shows a firm, irregular, non-mobile 2 centimeter mass beneath the area of the resolved ecchymosis. Mammogram shows coarse calcifications and radiolucent centers. A core biopsy shows necrotic adipose sites surrounded by lipid-laden macrophages. Which of the following is the most likely diagnosis? So based on the history of trauma to the breast and now with the lump and necrotic fat, this is most likely fat necrosis. So this is going to be an example of non-enzymatic fat necrosis. So let's see why. So today we're going to be talking, one of the things we're going to discuss is fat necrosis. So when we look at fat necrosis, it's a destruction of adipose tissue with release of free fatty acid. And then those free fatty acids that are being released, now calcium is going to bind to them because as we know, whenever you have necrosis, calcium tends to gravitate towards those areas. So the calcium is going to combine with those free fatty acid and that will form a chalky white deposit. And this is a form of what we call saponification, right? So when you add calcium to free fatty acid. So the when we look at the mechanism of fat necrosis, so it could be the one that is guided by enzyme. So if enzyme is involved, we're going to call it enzymatic fat necrosis. And if there's no enzyme, then it's going to be referred to as non-enzymatic fat necrosis. So let's start with enzymatic fat necrosis. So enzymatic fat necrosis is seen classically in acute pancreatitis. So it's seen classically in acute pancreatitis. And when you look at the pancreas, right? So in the pancreas, remember the pancreas has endocrine function and it also has exocrine function. So when you look at the exocrine function of the pancreas, right? Some of the enzymes that are released from the pancreas is trypsinogen, right? And this trypsinogen, because it's one of those enzymes that helps to digest protein, right? So they are released in the form of zymogen, right? Which is an inactive enzyme. So they get activated once they get to where they're going to in the GI tract, where they're going to be able to help with protein digestion, right? But if somebody have, in the case of acute pancreatitis, right, which could be due to gallstone, right, or if somebody is drinking a lot of what? Alcohol. So those could cause acute pancreatitis, and that will lead to activation of this enzyme in the pancreas. And once those enzymes are activated in the pancreas, so they start to digest the pancreas, because the pancreas is also made up of what? Protein. So they will start to digest those pancreas. Then the lipase, right, which is also produced, right, one of the way we produce our lipase from is from the pancreas. So that lipase now, so the lipase, right, is going to be released into the surrounding tissue, right? So to get to the surrounding tissue. And as we know, surrounding the pancreas, we have some what? We have some fats, right? We call them peripancreatic fats. So we call them peripancreatic fats. So this lipase now is going to start working on these peripancreatic fats. So to start to break them down, and as it's breaking them down, it's going to release what? The free fatty acid. And this free fatty acid now they're going to combine with what? Calcium, which is what we call saponification. So that process is saponification. And of course, this type of calcification, because this calcification occur as a result of inflammation, necrosis, then this is going to be a form of what? Dystrophic calcification. So in acute pancreatitis, there's release of pancreatic lipases, which act on peripancreatic fat and the mesenteric fat, causing hydrolysis and rupture of the adipose sites and release of free fatty acid. And then this free fatty acid combined with calcium to form soap, which is a process that we call saponification. And this is a form of dystrophic calcification. So when you look on gloss, right, so you're going to see chalky yellow, white deposits, right, which are the product of this saponification. And on microscopy, we're going to see pale outline of fat cells that are filled with amorphous, granular, and the basophilic staining calcified area. So when you look at those areas, they're going to appear blue in terms of the microscopic appearance. So let's move on to the non-enzymatic fat necrosis, which is another form of mechanism. So like we mentioned, with non-enzymatic fat necrosis, this does not involve enzyme. And they usually due to a trauma, right, to a place where you have a lot of adipose, like the breast, like the abdomen. And that leads to fat cell rupture, and that leads to inflammation. And because of that inflammation now, calcium could deposit in that area, thereby leading to the chalky white appearance that we could also see. So most of the time, the patient does not remember the event of the trauma. And a fat necrosis of the breast is a classic example, like the question we saw earlier. And abdomen due to trauma, right? And a fat necrosis of the breast. So when you look at it, they are usually very hard mass, and sometimes it could mimic breast cancer. So which is why that case that we saw earlier, that patient had to undergo mammogram and a subsequent biopsy, right? And on gross, again, you're going to see those on your microscopy, right? So you're going to see those fat cells with basophilic staining calcified areas. So moving on to another form of necrosis, which is gummatous necrosis. So this one is a variant of caseous necrosis. And guys, if you have not watched the video on caseous necrosis, I would definitely encourage you to watch that video whereby we talk about granulomatous inflammation. So this is a form of variant necrosis that is due to Treponema pallidum, which normally causes syphilis. And this gumma is classically seen in tertiary syphilis. Because if you look at syphilis, we have different stages of syphilis. There's congenital, primary, secondary, tertiary. But one of the manifestations of tertiary syphilis is granuloma, right? So the gummas are most commonly located, you can see them in the skin, in the bone, and they could be soft. They could also be in the testicle, liver. And if you see them in the liver, we call them the hepata lobatum, right? And there was a mechanism of this gummatous necrosis. So it's also a form of type 4 hypersensitivity reaction, right? Remember, type 4 hypersensitivity reaction is involved in the formation of granuloma. And just a quick recap for type 4, right? You have an antigen, right? And that antigen is taken up by the what? Antigen presenting cell. And the antigen presenting cell is going to be, in this case, is going to be macrophage, right? Remember, other antigen presenting cells include things like dendritic cells and B cells, right? And this antigen presenting cell now is going to present the antigen to what? To T helper cells, right? Which is our CD4. And this T helper cell now, right, is going to release what? Interferon gamma, right? And this interferon gamma is going to now activate the macrophage, right? And then the macrophage is going to now release TNF alpha. And then this TNF alpha is going to induce the granuloma formation, whereby your macrophage appear as epithelioid, right? And then it's going to wall up those infections, and they'll be surrounded by lymphocytes, fibroblasts, fibrosis, right? And then with time, calcium could also deposit there, thereby leading to what? Dystrophic castration. So please, if you have not watched the video on granulomatous inflammation, check out that video. And then when you look on gross, so it's going to be farm and robbery. And microscopy, when you look at them, they're going to have, like we mentioned, they'll be surrounded by a rim of fibroblasts, macrophages, lymphocytes, plasma cells, and occasionally multinucleated giant cells, just similar to what we see in granuloma, right? And very rarely you can identify the treponemes in those tissue, which is the bacteria that's causing the syphilis. So moving on. So what's going to be the endpoint of all this necrosis we've been discussing? So one, there could be a total clearance, right? So we can clear out all those necrotic tissue, either by enzymatic digestion, fragmentation, or phagocytosis of the debris by our macrophages, right? And then secondly, there could be gangrenous formation, right? And then lastly, there could be a dystrophic cascade. And of course, we're going to cover gangrenous formation and then calcification. So let's now talk about gangrenous necrosis. So that leads us to talk now about gangrenous necrosis. So gangrenous necrosis basically is a decaying necrotic tissue. So it's a necrotic tissue that is decaying. And then mostly it's due to coagulative necrosis. Remember, we mentioned earlier that anytime the blood supply is compromised, that will lead to coagulative necrosis. But remember the exception. In the brain, what we're going to have when the blood supply is compromised is going to be liquefative necrosis. So this is mostly, so gangrenous necrosis is mostly due to coagulative necrosis, but it will also be due to severe inflammation that could compromise the blood flow or severe bacterial infection. So if somebody has severe inflammation, like the acute pancreatitis or appendicitis, whereby the tissue are very swollen and edematous, that could compromise the blood supply, and that will also lead to what? Gangrenous necrosis. Or if somebody has like a very severe bacterial infection leading to edematous of those tissue, that will also compromise blood flow, as we're going to see when we talk about acute inflammation, and that will also lead to what? Gangrenous necrosis. So there are two major types of gangrenous necrosis. So we have dry gangrene, wet gangrene, and of course under wet gangrene we also have what? We have gas gangrene. So let's start with dry gangrene. So from the word dry gangrene, so that means when I look at this gangrene, they're going to be dry. They're going to be dry. And a dry gangrene is usually due to severe ischemia from arterial occlusion. So if you have like a gradual arterial occlusion, for instance, like somebody who have a form of peripheral arterial disease due to atherosclerosis, remember with atherosclerosis, it's normally cause a gradual narrowing of the tissue. And at the end of the day, that usually presents as a form of dry gangrene. So coagulative necrosis, whereby the tissue will be dry and black, right? So when you look on gross for dry gangrene, the affected part will be dry, and they're going to be very small and black, which is what we describe as mummified tissue. And when you look at them, they usually have a very clear demarcation, so you can actually see where the black tissue starts from. And so what's causing this black color? So the black color that we see in dry gangrene is due to iron sulfide that is produced from the reaction of hydrogen disulfide with the hemoglobin from hemolyzed red blood cells. So that's what gives it that black color. And of course, with microscopy, you're going to see necrotic tissue with indistinct appearance. So moving on to wet gangrene. So from the word wet, so that means when you look at the tissue, it's not only black, but it also appear what? It also appear wet. So this is when you have, so it could be when you have ischemic tissue and with a superimposed bacteria. So like somebody who have a dry gangrene, and now that dry gangrene is now infected with bacteria, and then neutrophil moves to that tissue, and as you know, neutrophil causes inflammation, and now they are wet, right? It could also be due to bowel infarction. So if you have a loose tissue and there's an infarction of that tissue, as we're going to see later, with infarction to a loose tissue, you can get what? Hemorrhagic necrosis. And of course, with hemorrhagic infarction, that could lead to what? Wet gangrene. So bowel infarction and an infected wound, all these are all examples that will lead to wet gangrene. So coagulative, so a patient will have coagulative necrosis, and then now there's now superimposed of infection, or there's now liquefied necrosis happening due to neutrophil moving in, right? That could lead to wet gangrene. Or if somebody have a loose textured organ like tissue, example like the bowel, the testicle, right? And their blood supply is compromised. So that could lead to what? Hemorrhagic infarction, and that could lead to wet gangrene. So when you look on gross, so you're going to see soft, swollen, decaying, rotten tissue with that color. And then the most important thing here is that when you look at them, it lacks a clear demarcation. Remember, as opposed to what we see with with dry gangrene, whereby you can see a clear demarcation. And on microscopy, you're going to see necrotic tissue with those acute inflammatory cells like the neutrophil, exudates, and a thrombosis of those blood vessels could be seen. Moving on to the last one, which is gas gangrene. So gas gangrene is when you have a bacteria that's producing gas in the tissue. So this is a form of wet gangrene. So it's a form of wet gangrene, and due to gas forming bacteria, particularly Clostridium perfringens. So those Clostridium perfringens, because they are anaerobic bacteria, so they do produce gas, right? So anaerobic bacteria produce gas bubbles of carbon dioxide. And then when you look at those tissues, when you examine them, you're going to feel what? Crepitus. So those crepitus are due to gas in those tissue. And they will also have foul-smelling odor and a mild necrosis, so the damaging of those death of those tissue. So what's forming this gas? So this gas, they are due to fermentation of sugars by the bacteria toxin. So the fermentation of sugars by the bacteria toxin that produces those gas, right? And this could be due to trauma, or if somebody have trauma to those wounds, that could lead to gas necrosis. And then the first picture there is just showing a dry gangrene, so you can see those feet there, and you can appreciate the demarcation, right, from a normal tissue. And the next one here is an X-ray from somebody who has a wet gangrene, now complicated by gas gangrene. And once now I want you to appreciate there, you can see those gas in the subcutaneous tissue, and you can see how swollen that leg is. So this one you need to call a surgeon start to come and see the patient, in addition to giving your antibiotics. So we've come to the end of today's lecture. So let's do some questions together. So the first question there, a biopsy in a patient with untreated tertiary syphilis reveals a rubbly nodus with granulomatous inflammation and central necrosis. This finding is termed Gummatous Necrosis. Remember, like we mentioned earlier. Second question, a 47-year-old man with a history of heavy drinking, right, with severe epigastric pain radiating to the back. Lab show amylase and lipase are very elevated. Over the next 48 hours, he developed numbness around the mouth and a capospasm. So why? Because if you guys remember, when we talk about enzymatic fat necrosis, as you are releasing your free fatty acid, what those free fatty acid doing? They bind to calcium. So because they are binding to calcium, so that means you are consuming the calcium in the process of what? Saponification, right? And then because of that, those patients will develop what? Hypocalcemia, right? So this patient is having symptomatic hypocalcemia as a result of saponification, as a result of we are consuming those calcium, right? So this patient has numbness around the mouth and a capospasm. Which pathologic process best explains electrolyte abnormality? So the best answer there would be what? Enzymatic fat necrosis with calcium soak formation. And then the last question, a 68-year-old man with poorly controlled type 2 diabetes present with a foul-smelling ulcer on the right foot. The area is black, swollen, and wet with purulent discharge, and a crepitus is present. Which mechanism best describes the type of necrosis that's occurring in this patient? So based on what we see, so this patient has an infected wound, and now we now see gas under the tissue as the evidence of the crepitus, right? So this ought to be a form of liquefative necrosis due to bacterial infection. So this patient likely has maybe Clostridium perfringens, which is a form of anaerobic infection that's causing wet gangrene. And the type of wet gangrene is what? Gas gangrene, right? And then we've come to the end of today's lecture. Please, guys, don't forget to like, subscribe, and then follow us on our social media platform. And I will see you guys in the next video.